Lobotomies are very taboo in neurosurgery. They were kind of doing it for anyone. People would take their wives who were seen as hysterical and take them to these gents to get them lobotomized. They were misused a lot, and people were turned into, for want of a better word, vegetables. Hey, I'm Alex Alamri. I'm a neurosurgeon in training down at St George's Hospital in beautiful Tooting, and I'm here with LADbible to do an episode of Honesty Box. So, what is a neurosurgeon? Neurosurgeons are neurological surgeons, used to be called neurological surgeons, and that means we operate on anything that is brain and spinal cord. So that's anything from brain tumours, problems with blood vessels in the brain, to anything like decompressing or relieving pressure on the nerves in the spinal canal. So very broad question, but in essence, we operate on the brain and the spinal cord. And some neurosurgeons also operate on what we call peripheral nerve, which is the nerves that come out of the spinal cord, let's say to the arm or the leg. Oh, do you learn on animal brains? Which is most similar to ours? So no, we don't learn on animal brains, we learn on you. Surgery is an apprenticeship model. It's just like being a carpenter. You learn by doing, and you learn in a really supervised, close environment where people are watching you like a hawk, and they keep watching you and letting you do little bits of surgery sequentially. It's supplemented by cadaveric training, which is operating on dead bodies. And these are people that have donated their bodies and brains to science. So we'll often do that. Animal brains, not so much, but again, we do animal courses where we learn how to, what we call, instrument the spine. So putting in screws and rods into the spine. Pigs and sheep are really good for that. Is it true that the brain has no pain receptors? Yeah, it's true. The bit of the brain that does have pain receptors that people feel during awake surgery is the covering of the brain, which is called the dura, which literally means hard or strong in Latin, and it's like a leathery covering. It's when we cut that people feel it, and it has a lot of blood supply to it, so it bleeds a lot, so we have to burn it in little places to stop it from bleeding. That's the bit that patients feel that hurts. It's not even the drilling of the bone that's not painful, it just feels weird. So yeah, the covering of the brain is the bit that really hurts if you don't get it right. Right, it's a good question. Are patients awake during surgeries, and why? So you can do surgery awake. You often see it for things like brain tumor surgery or deep brain stimulation. Let's say a brain tumor is pushing on an area of your brain that's really important for how your arms work or how you speak or how you understand speech. We've got lots of ways of staying away from those areas, but sometimes if we want to get a really good, what we call resection, or taking that tumor out, it means we're going to be operating very close to what we call eloquent cortex. And that's the part of your brain that's really important for all the things that make you and me us. One way is to put electrodes around the brain and do what we call neurophysiological monitoring, where the impulses get sent to a computer that's monitored by a technician, and then they'll say, oh, this is firing off a bit more than usual, or it's not firing off, stay away. But what you can sometimes find in those kinds of surgeries is that even if the recordings looked good and you stayed away from everything, the patient still wakes up and they've still got a major problem. So some surgeons like to do things awake, and that means that when you're operating in and around an area that's surrounded by eloquent cortex, it means that every time you do something, you can test the patient. And if you're operating near a speech center, you can talk to them. You can ask them to do specific things, say specific things. And if, for example, you're operating on a tumor and they start getting slurred speech, you know that you're straying just a little bit too far from where you need to go. Or that you just can't take that piece of tumor, for example, without making them profoundly disabled.
And generally, do you have people that are kind of really terrified if they're awake during brain surgery?
Yeah, when we do plan to do awake surgeries, it takes a long time to counsel patients. It is an extremely traumatic thing to put someone through, right? You know, they'll be awake, then they won't feel the skin being cut, for example, because we'll use local anesthetic to block the scalp. But drilling the skull It's a really horrible feeling, and it creates a kind of chatter that they can feel and hear. There's something you've really got to counsel patients about super well before the operation, and talk them through it while you're doing it. Good surgeons are often able to talk patients through it while they're operating and say, look, drill's coming now, it's going to feel really weird, it's going to sound really loud, everything's okay, everything's under control. The other thing is, when we operate on patients who are awake, they've usually got a frame around their head with pins in their skull, usually. That means that they can't move. So that means that their head is fixed, even though their arms and their legs may be able to move. That can often be a lot more traumatic for people, but also it's super tiring. So after about an hour, hour and a half, sometimes 2 hours of operating, you'll often find that patients are getting really tired. Their neck is held in a really uncomfortable position. They're getting cold even though we're trying to warm up their body and so on. So once they get tired, you really have to just start thinking about stopping the operation, and you've done the best that you can.
What if someone were to sneeze?
So having the pins in somebody's head in the frame means that even if they sneeze, things don't really move. You'll have very minute jerking movements, but nothing enough to cause an issue. So yeah, it's a good question. What if they sneeze? What do you think of cyclists who don't wear helmets? First thought that comes to mind is, I only say this because I get to operate on cyclists who don't wear helmets, and in surgery we call them practice cases. You are literally creating a practice environment for surgeons. I've seen people come off bicycles extremely low speed just down the road from here and operated on them, and they've never been the same again. Professionals, young professionals, at the height of their careers, who have literally gone over the front of their handlebars at walking pace and are now severely brain injured. So if you don't want to wear a helmet, don't. Just understand that it doesn't really take much for your brain to change forever. And we'll do what we can, but it's probably not going to be enough. Does brain size really equate to level of intelligence? No, it doesn't. It was a really popular thing back in the day. Einstein's brain was harvested, dissected, even sent to his mates in the post to kind of try and figure out whether, what the seat of genius truly was. And I'm going to say something I'll probably keep saying, is that we don't really know what defines human intelligence. The way the brain works is kind of experiencing a bit of a renaissance academically, where everything is seen in terms of something we call connectomics. Imagine it like Lego, and you've got loads of pieces of Lego. All the pieces of Lego are super important. You lose one, you're going to have a problem. When you start to put the Lego together, you start to see what it all starts to form and it starts to take shape. So within certain parts of the brain, you take all those little bits of Lego, you create something with it, and then you have a piece of the brain that does something. But then there's another piece of the brain that will interact with that other piece of Lego network. And it's the way these two gel and the way these two interact that probably defines intelligence and all sorts of other functions within the brain. So it's more about how the brain is interacting with other parts of it and how they interact and network together, more than what one little part of your brain does. I don't think it's as simple as to say, this part of your brain is for intelligence, this part of your brain is for moving. There are some parts of the brain where you can definitively say, like, this moves your arm, this moves your leg, this helps you speak. But when we talk about something complex like intelligence, it's a complex question, you need to expect a complex answer. So it's how the whole brain gels together and works together. Does surgery ever go fatally wrong? Yes. Yes, it does. It can go fatally wrong on the operating table, or it can go fatally wrong after you finish the operation and you transfer the patient to the ward or the intensive care unit. And it may not necessarily be what you as a surgeon have done. It might just be the disease process itself just rapidly, taking a patient's life. The thing that we worry about the most, for example, in trauma surgery, is something called mushrooming. And again, this is super graphic. So if you want to not listen to this, that's also great. So in big traumas where, cyclists who don't wear helmets hit their heads and have a massive blood clot over their brain and they're in coma and we need to operate on them. We do a massive cut and take a large piece of bone off about the size of your hand, pretty big. That's called a decompressive craniectomy, which literally means decompressing, and craniectomy means taking the bone off and discarding it. What tends to happen, if you're unlucky, is you cut open the dura, that tough leathery covering, you splay it all out, you take off the blood that's pushing on the brain, but often the brain itself has taken such a big hit that it's, for want of a better word, dying in some areas. We call it ischemia or necrosis. And that causes the brain to swell. And if we see the brain swelling, there are a few things that we can do during the operation. The basic maneuvers, different drugs that we can give, but that's just buying you a little bit of time. Once the brain starts swelling, it starts mushrooming through the hole that you've made. Once that happens, you have to just get out as quickly as possible, close the skin and get the patient to the intensive care unit. I've seen brains mushroom very, very rapidly, and if you can't get the skin closed, it can be fatal. Some people will resort to having to take away parts of the brain to make room to get the skin closed. That's usually really bad. People tend not to survive that. So yes, it goes fatally wrong sometimes, and when it does go really wrong, it goes super wrong.
How do you feel in those moments?
Shit scared, basically. There's a part of you that's trying to take control and trying to think about what the next steps are, and you're trying to preempt different things. But there's also a part of you just screaming, thinking, get it closed, get it closed, get it closed. And yeah, it's a bit of a team effort, and usually calling in a couple of other friends and colleagues to help you do the right thing, whether that's taking a piece of brain, if needs be, in really, really extreme circumstances, or liaising with your anaesthetic colleagues to try and get the brain swelling down, even if it's just for a minute, just so you can get things closed. So yeah, it's very much a shit yourself moment. What does the brain feel like? It's kind of like, some people will explain it like foie gras. It's not like foie gras. It's a little bit tougher than foie gras. It's a little bit springy and a little bit bouncy, very soft, and looks incredibly beautiful. Can brain surgery really change people's personalities? Yes, absolutely. It can definitely change your personality. I've seen it. Sometimes it lasts for a long time, sometimes it lasts forever, but sometimes it's really transient. It doesn't last that long. And it could just be a direct result of just fishing in and around a tumour, for example, causing a little bit of pressure on other areas, and then it settles down, gets better, and it's fine. Sometimes, though, people's personalities can change quite dramatically and for a long time. So yeah.
And when you say a little bit, like for a kind of short period of time, what kind of changes are you witnessing? Is it changes in mood or?
Yeah, it can be changes in mood. It could be a change in memory, and obviously memories are a massive part of your personality. Short-term memory being affected, people not being able to recognise family members, not remembering why they're in the hospital or what they've had done to them, to other things like being what we call a bit frontal, which most people know, which is just kind of having no barrier between their brain and their mouths and just saying whatever they want, doing whatever they want. And in really rare scenarios, things like psychosis can happen. That's happened a few times in the past few years, where patients have tried to commit suicide and so on and so forth. So we keep a really, really close eye. Probably the weirdest thing I've seen is someone having brain tumour surgery at the front of their brain, and then I saw them the next day on the ward round, and they were really horny, and they were masturbating under their sheets, just making direct eye contact. And it was one of those times where I just kind of giggle a little bit and, all right, we'll just leave you to it, close the curtains and leave. But that's probably the weirdest thing from a personality thing I've seen. Not that weird for most lads, to be honest, I don't think. But the next question is, what is a brain tumour? So brain tumours can be split up into benign, or the things that are not cancer, and cancerous tumours. There's a big misconception about this. A lot of the times, and many times where we operate on people, they're for benign brain tumours. So within the brain and the spinal cord, it's not necessarily what type of tumour it is that will push you to operate. It's what it's doing to the surrounding structures, like nerves or different important parts of your brain. A benign brain tumour, if it grows and it grows rapidly or starts pushing on other things within your brain, you might need to operate on that much more urgently than a cancer, for example. So the what is a brain tumour question is super broad and don't have enough time to get into every different type of brain tumour. But I think it's important to kind of divide them into cancerous, non-cancerous. But the fundamental thing is, what are they doing to your brain and spinal cord? Does it need an operation to remove it? That's when we get involved. Did lobotomies work? Lobotomies are very taboo in neurosurgery. And they're generally just very taboo in culture. Like most neurosurgical techniques that were developed in the early Victorian periods and before that, they all work and they all do something very specific. The problem is, once these techniques get used for something they shouldn't be used for, or once they become popularized, that's when you've got a really big problem. So lobotomies were developed in, I want to say, the mid to late 1930s, early 1940s, and popularized by a couple of American chaps who decided to take it on the road in their van and use ice picks to do these through the orbital roof, just up through here, under the eyelid. They were kind of doing it for anyone. You know, people would take their wives who were seen as hysterical and take them to these gents to get them lobotomized, to calm them down. This is obviously not how neurosurgeons do things and not how we work. There's always a very, very specific reason to do a specific surgery for a specific kind of problem. So lobotomies were developed, they were popularized and used a lot in the psychiatric field in the middle of the last century. They were misused a lot, and people were turned into, for want of a better word, vegetables. Their personalities were changed. They became very mute. They just became shadows of themselves and were left in psychiatric institutes to rot. And that's why we don't talk about lobotomies very much, even though there are still some indications for not lobotomies in the way you know them, but specific types of brain surgery for pain, for example, like a cingulotomy. And that can be very, very useful for patients who are experiencing pain that is just not getting better with medication or any other kind of surgical treatment for chronic, awful pain coming from their nerves. So there is a role for these kinds of operations as long as you choose the right technique for the right patient. But the sooner we talk more about lobotomies and the taboos around them, the sooner we can progress the field of psychosurgery and deep brain stimulation and actually move things forward and make things better for patients that might need these kinds of operations. Will a brain transplant ever be possible? Yes, you probably will be able to. I'm probably going to have to eat my hat after this. It's not just a case of hooking up the plumbing. It's a case of rewiring the nervous system, which is the hard bit. And I don't think there's anything that can do that just yet. We've got things like stem cells that can encourage what we call neuroplasticity, where the nerves can start to kind of rewire a bit. But it's like what happens in phantom limb syndrome or all sorts of other things where you've got like a cut to a nerve or damage to a nerve. It can grow back in some cases, sometimes not. But often when it doesn't quite grow back with a normal function. So it may fire off more pain signals, for example. And this is a super simple way of thinking about it. But then imagine trying to do that with a spinal cord that has hundreds of tracts running through it with loads of complex information coming from your body to the brain and from the brain to the body. If any one of those little tracts rewires wrong, you're going to have a major problem on your hands. So probably will be possible. We're nowhere near it. Nowhere near. Step by step, how do you remove a brain tumour? So everyone, I'm going to show you how to do it right. Let me go through the basic steps. Okay, let's say you've got your patient prepped and you've got them ready. You've cleaned the skin, you've put some local anaesthetic in the skin, the patient's completely asleep or they're awake, whatever. You make a cut in the skin, and then the next step is to take a piece of bone off, and it should be just big enough to allow you access to the tumour, but not too big. Then you're confronted by the dura that we spoke about before, that tough leathery covering over the brain. You need to snip that open quite carefully, because just underneath it are all the major veins draining blood from your brain. And if you nick one of those, you can give your patient a stroke. You open up that leathery covering, and then if you're really lucky, you'll be confronted by a tumour sitting right there in front of you. And then it's a case of just working around it, creating a kind of plane around it, making sure you don't rip any blood vessels or anything like that, making sure you're not pushing the surrounding brain too much, etc. If the tumour is a bit deeper, then you're going to have to go through normal brain to get to it. And that's where your training as a neurosurgeon is important. And that's where the planning comes into it. So you will have chosen your trajectory and where you make the cut and where you remove the bone, not necessarily to be directly over the tumour, but over a piece of brain that will allow you to approach the tumour without doing too much damage. And at that point, you'll go through a bit of normal brain. I won't go through the exact steps. Find the tumour and just, again, start slowly creating a plane around it and trying to shell it out. Afterwards, you can't just leave the gap on the hole. The brain likes to bleed a lot as a result. So we make sure that before we come out, we've stopped any little bleeding points, use lots of different expensive things to stop the bleeding and stop it happening later. Leave a drain just underneath the skin, a bit of plastic tubing that comes out of your skin and hooks up to a bag by your bedside to drain any excess blood. Can you see AI assisting surgery? Yes. Neurosurgery is probably one of the most technically advanced surgical fields. So we've got a lot of stuff that helps us. Robotics, speech recognition, robotic arms that can move cameras and microscopes. And soon, I think AI will be really useful in radiology. So that's looking at scans, CT scans, MRIs of patients, and so on. As surgeons, we look at a lot of scans, we make a lot of diagnoses, but we're not radiologists. And even radiologists have a lot of trouble defining, is something cancerous, is it not, for example. And until you go in and take it out, you don't know, really. From an image recognition perspective, AI is going to be massive for surgery and neurosurgery specifically. Diagnosing, prognosticating, all sorts. Anything that requires imaging within it, AI is going to massively help us with. And I'm a massive proponent of AI. I think it's certainly one aspect of the future for surgery, especially neurosurgery. What are the risks of any given surgery? There are some pretty broad risks that we tend to counsel patients on, whether they're going for a brain tumour surgery or a blood vessel surgery or something along those lines. The main ones tend to be bleeding during and after the operation. After, we tend to be a bit more worried about, because you can do a really great operation and the patient can do really well, but then there's a bit of a build-up of blood afterwards that causes compression of something, pushing down on really important structures. A few days down the line, it'll be infection that we really worry about, especially in the brain and spinal cord. Anytime you open the head, we worry about seizures, especially if we're operating in and around the temporal lobe. That's what we call an epileptogenic focus. So that's an area where if it's when the air hits the brain there, or where you've manipulated it or done something to it, the patient can get seizures afterwards. So we have a very low threshold for that. Another one, especially in spine surgery, is a leakage of brain or spine fluid, cerebrospinal fluid. And that's not necessarily because leaking of the fluid is in and of itself a problem, but it can stop wounds from healing. It can cause really weird symptoms that can't be explained. And on the whole, we try to avoid it, patch things up, and monitor people really closely afterwards. Those are the three main ones. And then there are the other things like paralysis, stroke, risk of death, all that kind of stuff, which are a lot lower on the pecking order, believe it or not, but they do happen. Do you ever get an existential crisis? Yes, I do. At the beginning of my training and career, it was looking at a brain when you're operating and just thinking, I really don't know what I'm doing. I really don't know what this is. I've got so much yet to understand, so much to know. Will I ever know enough? Blah, blah, blah. There's that kind of existential crisis. Then as you approach the kind of middle of your training and latter ends of your training, like I am, the crisis tends to be, why am I doing this? So that could be like a really severe trauma where you don't think someone's going to do particularly well, but you're trying to give them the best chance of recovery. But you know deep down inside that that's going to be quite unlikely. When you see your first child diagnosed with a brain tumour, you see a bubbly little girl running around, smiling, happy, that has something really catastrophic going on inside of them. And I've got 2 young daughters, so I find that hits me a lot harder now than it did before. So yeah, existential crises, I get loads of them all the time, for loads of different reasons. Are surgeons psychopaths? Your version of what a psychopath is probably, it probably stems from social media, film, etc. We're looking at people that have zero emotion, very, very blank, don't care very much. Surgeons are not psychopaths on the whole. They may have psychopathic traits. They may look and seem emotionless, but usually it's a bad coping mechanism for seeing really seriously horrible things. Some people I know laugh when they see horrendous stuff. I've seen someone having chest compressions because their heart has stopped and their skull's been split open in a brawl, and bits of brain are coming out, and I laughed when I saw that. It doesn't make me a psychopath, it's just a trauma response. Never seen anything like it, probably never will again, but different people deal with it in different ways. Some people might cry, some people might not say or do anything. I didn't laugh in front of my colleagues, it was just a kind of internal feeling like I need to giggle because this is so horrendous. But you have to put on a kind of face, like something truly awful is happening just in front of you that you've probably seen only in a horror film from the 80s, and you can't really start crying or whatever, because there's an element of professionalism that's expected from you. And often as a neurosurgeon, you're the only person in the room that can give an opinion on whether something can be salvaged or fixed. So you have to be quite professional. And often people will equate that with psychopathy. Because they'll say, how are you so dead in the eyes about it? It's like, I'm not. I've just seen a lot, and I can't show you how I'm feeling right now because we've got a job to deal with. That's often why people view us as psychopaths. What is brain death? Again, what you may have seen from films and TV series and things like that is that you might have someone that has had something catastrophic happen in their brain, but their heart is still beating, they're still breathing, with help from intensive care and tubes and so on and so forth. It's not a simple answer. There are a few different criteria that we use to assess for brain death. It's done by 2 consultants who will do the testing separately, and they're testing what we call primitive reflexes. So once the rest of the brain has taken a massive hit, there are still some primitive reflexes that are still there in the brainstem. So it's called brainstem testing. And there's lots of different things that we do to test that, but it requires 2 doctors to do those, and then they will come to a consensus and then define whether that patient is brainstem dead or not. Do you enjoy your job? Most of the time, yes. Operating is great. It's what I want to do. It's a privilege, and it's something that I really, really enjoy. The problem is, and I don't want to start preaching about the NHS and our healthcare system, but it is an archaic system that is tragically underfunded. And as a result, most of the people that I work with, and I won't tar everyone with the same brush, but most people will agree that it is not the job that we thought that we would be doing. We're doing more bureaucracy, admin, clinics, and service provision that is not operating than we are doing operating. And I would say that most of my colleagues are probably spending more than 50, 60, 70% of their time in a week doing stuff that is not operating. And it's stuff that doesn't need to be done by a surgeon 9 times out of 10. More than anything, it's a waste of resources, it's poor use of resources, and it just leads to low morale and just a really real breakdown in the job, to be honest. I think people probably enjoyed being a surgeon a lot more 20, 30, 40 years ago than they do now. I'm not saying it doesn't have its benefits. I'm not saying it isn't a great job. It's just really, really difficult to do the bit of it that you love, which is operating.
Do you think it's morally right to perform this type of surgery? I was waiting for this question, it always comes up. Of course it is. The patients I deal with are trans women, so they start out with male anatomy, but they have a female gender identity. If you don't offer them appropriate support, counselling, and in the end surgery, we think about 1 in 5 of them commit suicide.